Now, let me introduce you to Alpana Mair, Head of Prescribing and Therapeutics for the Scottish Government, coordinating delivery of government's work program and advising ministers on quality, safety, and effectiveness of the use of medicines. She is responsible for development of national polypharmacy clinical guidance, patient app, and shared decision-making tools. Alpana has recently been awarded European Union funding for implementation of polypharmacy program across 3 countries, iSympathy, and leads successfully delivery of European funded project Sympathy, stimulating innovation in the management of polypharmacy and adherence in the elderly. Leads work for WHO on polypharmacy and is an expert advisor and consultant for the WHO. For the International Foundation of Integrated Care, IFIC, she coordinated the Special Interest Group on Appropriate Polypharmacy and Adherence and is the European Union Coordinator for work on active and healthy aging on polypharmacy and medications adherence. As a Quality and Safety Fellow, she runs clinics and has received funding to develop a street outreach to improve homeless people's management of multiple morbidities and medications with third section partners. She is Senior Lecturer in Prescribing at the School of Health and Social Care, Napier University, Robert Gordon University, and an Honorary Lecturer at Strathclyde University. She has previously the Deputy Chief Pharmaceutical Officer for Scotland. Alpana will present her conference entitled Addressing Polypharmacy Targeting High-Risk Medicines. We invite you to actively participate during this presentation. If you have any questions, please ask them in the chat on the left. We will be responding to as many as we can during the allotted time. The rest of the questions will be answered and published in our Q&A section within Patient Safety Day on our webpage, isoponline.org. Without further preamble, please give a warm welcome to Alpana Mair.
Thank you very much for that warm introduction, and I'd like to introduce you to the topic that I'm going to talk about, which is addressing polypharmacy by targeting high-risk medicines. So first of all, what do we mean by polypharmacy? And is polypharmacy always a bad thing? So polypharmacy simply means the taking of multiple medications. And for some patients, this might be completely necessary. For an example, a patient with cardiovascular disease might easily be on 10 or more medicines, and these could be perfectly needed for those patients. So this is what we refer to as appropriate polypharmacy. However, another patient may be on medications that are no longer providing them with the benefit, or the medicines are doing them harm and causing side effects, or we're not able to get the required clinical outcomes that we want from the medication because the patient isn't able to take it appropriately. In this instance, it's referred to as inappropriate polypharmacy. What we know that there are certain medicines that make the individual more prone to harm from medication-related harm. And we're going to have a look at some of those in a bit more detail. So multiple morbidity is common as we get older. So as we get older, more of us will have more than one long-term condition. And as you can see from the chart, you don't actually have to be that old to suffer from 2 or more long-term conditions. Why is this important in relation to polypharmacy? Well, usually that means that you're likely to take more medicines to help manage and prevent long-term complications from disease, and these are important. We also know that as people take more medicines, we need to work with them on their adherence. We know that people that take 4 or more medicines don't actually take them as you prescribe, so they may not be getting the clinical benefit that you think they are. So why is it that people end up on so many medicines? So first of all, let's focus at the picture on the left-hand side. All of us, I'm sure, go out and we buy our medications. We start at a very young age, it may be antibiotics, and then we'll start buying things or having things prescribed to us from different prescribers for various different conditions. I already explained to you that as we get older, we have multiple morbidities, so we start targeting those as well. And this isn't just the prescribed medicine. Let's think about the traditional medicine, or the medicine that your auntie gave you or your granny recommended. And there's herbal preparations as well that have some drug interactions and potential for toxicity. What we also need to bear in mind is that as people get older, or maybe they have a long-term illness and they present with their illness, some people can become frail, and when they become frail, they tend to take more medicines. And obviously these individuals as well are more at risk of renal and liver disease. So this will affect how the body deals with the drugs and may therefore put the person at increased risk of harm from those medications. When we ran the Sympathy project, one of the issues that became very clear is that addressing polypharmacy is a public health challenge that we need to deal with urgently. And we need to address this when we start medication, but also when we review our patients to make sure that they are getting the benefits from the medication. So we know from research data that unplanned hospital admissions every year across Europe there are 8.6 million admissions every year due to medication-related harm. And 50% of these admissions are in people over the age of 65 or more, only taking 5 or more medicines. We know that if we looked at this data and we looked at it in 186 countries, work that the World Bank and WHO and various other bodies did, we would actually save 4% of the total avoidable costs from polypharmacy. That would equate to 0.3% of the global health expenditure. That's £18 billion. If you think about that, this could be used to provide better healthcare for people, to provide services such as medication reviews, which would help support the patient and help them get the optimum outcomes from their medication. So in 2017, in response to looking at this, we had the findings from the Sympathy project, and after that as well, the WHO launched the Global Patient Safety Challenge, Medication Without Harm. Now, this is their third patient safety challenge, and it's focused on medication safety because medicines tend to be one of the most common interventions that patients have. And they identified 3 flagship areas, and these were 3 key targets for countries to start working with. And these were medications in high-risk situations, medication safety in polypharmacy, and medication safety in transitions of care. So really what that means is when we're reviewing an individual's medication, we should think about the medicines that are going to put them at the highest risk of harm or any situations, but we should make sure that we do that across each healthcare setting, or when a patient moves from one to another, to make sure that there's no errors when that happens, and that we review our patients to make sure the medicines are still appropriate. So let me tell you a little bit more about each of those. So what we know, as I've said already, is that more people will have multiple morbidities than will have just a single disease. And what we also know is that we need to think about addressing appropriate and inappropriate polypharmacy, rather than just thinking that this is about a number. Numbers are important. We know that when people take, the literature often looks at 4 or 5 medicines, and we can sometimes use that as a benchmark, but we need to think about the individual and the medication. And we need to empower patients to be shared decision makers with us in this process. And the WHO has produced a tool called 5 Moments of Medication Safety that clinicians could use alongside having these discussions with their patients. So in the acute sector, one of the acronyms that's used often to identify the medicines that are causing most harm in the acute sector, you can say the acronym APINCH is used, and you can see here the list of medications that have been identified as causing the most error. And here we would want to make sure that if we were going to implement the reviews, that we prioritise patients that were taking these medicines. And we'll see that there is some overlap with these medicines and those that might also commonly be used in primary care. So I want to take you through a really one approach. It's highlighted both in the WHO report, but it's the guidance that we use in Scotland to make sure that we have a person-centred approach in order to address appropriate polypharmacy. So I'm going to take you through those 7 steps now, but what you can also see on the screen is that you can download, and it's available globally to anybody. It's the Polypharmacy Guidance app, and within that app there are pages and tools for clinicians, so that's yourselves that are undertaking the reviews, but also for patients. So they've got the shared decision tools that you can see on the sides there with the antiplatelets that would be used by a clinician to work with the patient so that they can help and make the decisions themselves. So step 1 then is about finding out what's important to the patient. So what's important to them can be very different to what might be important to the healthcare professional. So Melissa introduced me and explained that I work and do clinical work in a homeless practice. And when I was doing one such review with my patient one time, I had a gentleman that came in, and he was going in and out of hospital because he had a really bad asthma. And when I looked at his medication, I could see that he was taking his reliever, his salbutamol all the time, but he wasn't taking his preventative inhaler. But he was also on painkillers. And I thought, okay, when I'm doing a medication review with him, what I need to do is I need to help him take his steroid inhaler, and that way he won't need his salbutamol and his asthma will be better controlled and he won't go into hospital so much. However, when I spoke to this gentleman, I said, you know, what's happening? You know, what's the problem? Why are you not taking your medications? What he said to me was, Alpana, the problem is that I can't think about my breathing and my inhalers, because when I'm going to sleep at night, I'm in so much pain sleeping on the streets that actually I need to manage my pain better. And he wasn't looking for any more medication. What he needed advice on how to take his pain medication in a right way so that he could get the right benefits from it. So you can see from that finding out what's important to the individual will mean that you may do the review in a way that helps the patient be a partner in the shared decision making, but you can still address the outcomes that you need. So we addressed his pain management first, and then we went on to address his asthma by working with the patient and what was important to them. So the second bit really on here, the steps 2 and 3 are about identifying what's essential and what's unnecessary drug treatment. So when you have a patient's list and you're looking at it, the essential things will be things like thyroxine, insulin, but there may also be other things for treatment, for example, for Parkinson's, because you're trying to prevent symptomatic deterioration. So you may identify things in here that the patient is also not taking and that they should be taking. Step 3 is to try and help us identify, does the patient take any medicines that actually don't give them any benefit, or they're not going to be able to take it for long enough according to the drug trials to get enough benefit from it? And That way we can find out if the patient's going to benefit or not, or whether they're putting themselves at increased risk of harm. So let me give you an example to illustrate that. If we think about an elderly lady who might present after a cardiovascular event, we would need to treat more than 280 people for that lady to get a benefit from that medication, and she would have to take it for a number of years. So we would need to know, was she going to be able to do that? And it might affect our decision making around risk and benefit of harm to the patient. So that's looking at the numbers needed to treat. However, if we look at it in terms of mild heart failure, the number's close to 30. And if we look at it in terms of severe heart failure, it goes down to almost less than 10. So you can see that this information is really important in having the conversations with the patient about the risks and benefits of the medication. And these are some of the tools that we can share with the patient, and you'll find in the app that you can access. So we've started the medication, and what we should also then do is to think about, is it effective? Is it doing what we want it to do and achieving the right outcomes we need to do? And is it stopping a patient deteriorating with their symptoms? And if not, if it's not giving them benefit, we should review it, because we don't want to just add in another medication without reviewing what they're already on. And then that brings me on to thinking about the problems that we can then have if people are on multiple medicines. So thinking about the drug disease, the drug-drug interactions, but also thinking about if a patient does fall sick and they are on a high-risk medicine, do they know what to do? And I'm going to just talk about that in a little bit more detail. But focusing back in on, if we're going to review people that are on multiple medicines, so we know that the more medicines people take, the higher at risk they are of harm from polypharmacy. So we might want to target a population and target those that are taking the most medicines and maybe elderly, because they are more prone at risk of harm. So we would want to then think about, okay, which drugs do we want to look at? And so I'm just going to run through some of those with you. But before I do, I just want to sort of just explain to you another scenario, and this is from work that I did in a nursing home. So in one of the nursing homes, I was going in to do some polypharmacy reviews, and as I would go into the care home, I would often see a lady sat in the nursing home, and when I went in, she would look up and she would smile at me and say hello, and then she'd go back to sleep again. When we came to look at this lady's medication, I could understand why she was falling asleep, because she was on a high strength benzodiazepine, she was on an antipsychotic, and she was also on an antidepressant. Now, when I asked the care staff about why she was on all these medications, because when we came to review her, she had a history of cardiovascular disease. So immediately there's alarm bells going in terms of antipsychotics and cardiovascular risk. But the fact was that the quality of life of this lady wasn't very good, because she was drowsy all the time. So they explained to me that this lady, when she first came into the care home, had felt quite upset, and she'd been aggressive to the staff and other residents. So they'd had to give her some of these medicines to help settle her in. And so then I asked, well, how long had she been at the care home? And they explained to me and said, well, she's been here for 5 years now. And at that point, I thought, well, we need to have a conversation and think about reducing this lady's medicine slowly. So it's not to take away from the anxiety of the staff about the fact that this lady could become aggressive, but she had settled in the home. And so we worked with the staff and with the patient to slowly reduce her medicines. When I went into the home several months later, that lady wasn't sitting there, and I asked the staff, a bit worried and anxious that about the lady, and they said to me, "Oh look, she's over there, she's walking around." So you can see that actually that we sometimes need to make sure that we are the patient's advocate, and we address medications even if they've been on there for a long period of time and they look like they're difficult to remove. So let's think about the high-risk medicines, and you can find more detail in the article on addressing the challenges of polypharmacy. So the common ones that have been found in many studies, and one of the landmark studies being the one by Pierre Mohammed, are non-steroidal anti-inflammatory drugs, and looking at if people take these in a mixture, what harm they can take for a patient. So a third of all drug-related admissions and half of drug-related deaths are due to the inappropriate use of these agents. And the things that put patients at risk are the age, the prior history of peptic ulcer. So we need to check, is it appropriate for this individual to be on an anti-inflammatory drug? If there are absolutely no other alternatives, then we might need to think about, do we need to then protect them with a proton pump inhibitor? Obviously, the ideal scenario would be that we might find something alternative for the patient to take apart from a non-steroidal. Obviously, non-steroidals have also been implicated in cardiovascular disease, and if patients are also taking selective serotonin inhibitor antidepressants, again, that effect is compounded, and they may also be compounded further if the patients, for example, have chronic obstructive airways disease and they have courses of corticosteroids. The next group that we need to focus on, and I gave you the case scenario, is around antipsychotics. And it's an area that we do struggle with and need to work on doing more work on targeting those patients. Antipsychotics can safely be discontinued in patients with dementia that are inappropriately prescribed, and they need to be decreased on a gradual basis and the patient monitored. And we do need to question the appropriateness of the antipsychotic medication for the individual. So benzodiazepines, again, we find often that these are a group that predispose a patient to falls. And often what's happened is the patient's been initiated on this, but they've been left on them for longer than the 3 to 4 weeks, which is the recommended maximum amount. They can also impair memory, and obviously we all know that they can have the potential for addiction as well, and dependence, and then you're left with the multiple problems. Antidepressants also have, depending on the class, can predispose people to falls, and we need to sort of bear that in mind. And some of them, particularly the older tricyclics, can be cardiotoxic, and we need to make sure that we monitor that. And more recently, there's been a lot of attention paid to the fact that as you come to reduce the dose of the antidepressants, people can have a withdrawal reaction. The other group of medicines that quite a lot of focus has been done in terms of looking at polypharmacy are the medicines that as a side effect have anticholinergic effect, and it's been suggested that they can cause impaired cognition, increased risk of falls, and what we need to do really is to do a very individual patient review around this, because it is dose dependent, and the sensitivity to anticholinergic effects does vary between individuals. There are tools out there, but the evidence that's used to underpin them is limited, but they are useful to start with, on the understanding that what you then do is an individual patient review to see how it's affected the individual patient and make your decisions based on that. Now, centrally acting analgesics, opioids in particular, are ones that patients are often on, and patients often have unrealistic outcome expectations from medication to manage chronic pain. We know that probably they're only going to get about 30% of relief from the medication, and that they need to do other things alongside medication in order to manage chronic pain. Again, the problems here are falls and the potential for abuse and addiction. So we need to bear that in mind. And quite often these medications are used alongside the gabapentinoids, again, that come with their own side effects and possible dependence and abuse there as well. So one of the other areas to then look at are anti-hyperglycemics, and particularly for type 2 diabetics. And in here, the emphasis is that if we're managing type 2 diabetic patients, our focus should be initially on the lifestyle modifications in order to look at that in order to manage diabetes. Type 2 diabetic patients need tight glycemic control to prevent macrovascular complications, and it's fine for patients who are relatively fit and healthy. However, if we go for very tight targets for older patients, they sometimes can then be predisposed to hyperglycemia, which has been associated with increased mortality, falls, and we just need to balance the risk here with the patient. Now, it does take some time to build up the benefits from cardiovascular treatment, from anti-diabetic treatment in terms of blood sugar. And once that has been achieved, there is a legacy effect, so people do get a benefit. There does become a point, however, when the blood sugar level and the effect of harm, you need to sort of just balance that tipping point to make sure that you're not doing more harm than good. So it's about, again, doing a patient-centered approach and setting realistic blood sugar targets for your patients. So I've already mentioned many medications that have increased risk of falls, but it is important just to note that 30% of community dwelling older adults fall every year, and as people get older, that proportion increases. And we know that medications can be a factor that can have an impact, and that we can modify that. And I've talked about benzodiazepines, antidepressants and antipsychotics, but we also have other medicines like antihypertensives and diuretics. As people get older, they may suffer from postural hypotension, and we need to sort of make sure that people aren't falling because actually we're managing hypertension when actually as they've got older, their blood pressure is no longer an issue for them. And obviously people taking more drugs, and particularly if that's combined with fall inducing drugs, the higher the risk of harm and the risk of falls to these patients. I just then want to touch on looking at whether this is the same for everybody. So one of the things that we do need to think about is frailty, and frailty doesn't always go hand in hand with age. So think about the frailty of an individual. It may be for somebody who's younger that's frail because they have multiple morbidity. I have a lady, she's in her 40s, she has 3 long-term conditions, and she's on the frailty list, and she's the lady in her 40s. So don't necessarily go for age, look at the individual and their sort of body functions and their kidney and liver function, and take all of that into consideration when we're thinking about prescribing. The other chart and the data that I want to share with you is that multimorbidity can have an impact, as can deprivation. So we know that if you live in a deprived area, you're more likely to have long-term illness earlier. That means you're more likely to therefore take more medicines earlier, and therefore more likely to be predisposed to harm earlier. So we might want to think about how we target our services and focusing on stopping inappropriate high risk prescribing and addressing polypharmacy in younger patients like this. So does this work? Does this approach work? So what I put up here is some data that really shows that, you know, the work that we've been doing in Scotland since 2012, you can see the gradual reduction at a national level in the number of medicines people are taking, and particularly the older patients is where we started and focused our work on. And then if we focus in specifically on patients that are, if we look at the high risk combinations here, so you can see that this is a combination of people taking a non-steroidal anti-inflammatory drug, an ACE inhibitor, and a diuretic. Now this is a triple combination that can put people at increased risk of acute kidney injury, and you can see that across Scotland the PG 1, 2 and 3 indicates each time we updated our guidance. And each time there's been an improvement in that data, so less people suffering from harm from less harmful combinations of medications. So one of the final steps really is to, once you've done a review, is to agree that plan with the individual, because they have to take that home or their carer, and so they need to make sure that they're happy with the outcomes and they're going to happy to implement what you've both agreed together. So sharing the plan and sharing it with people that need it is really important, so that if you do stop any high risk medicines, it's very clear to other healthcare providers as well why you've stopped it. So thank you very much. I hope that you understand how we can address polypharmacy and high-risk medicines together by tackling those medicines that are at particular risk of harm to an individual. Thank you.
Alpana, thank you so much for your great presentation. It was really interesting. We have some questions from our attendees. Our first question is, according to this review that is performed on a polymedicated patient, do you also consider the natural and the homeopathic products, the vitamins, etc., that the patient consumes concomitantly with his or her pharmacological treatment?
Yeah, so I think that, thank you for that question. It's a really good question. And it's really important that when we are taking that drug history, that's one of the questions that we think about is what are you taking that maybe a doctor or a pharmacist or a nurse has prescribed for you, but what else are you buying that you take? Because we know that these medicines can have interactions, can have an effect on a patient's outcomes. We also sometimes find that patients may decide to take some alternative treatments rather than the one that the healthcare provider has prescribed. So that might mean that we think that treatment is failing and there'll be a temptation to increase the dose, but in actual fact, the person's made a decision to take something differently. So yes, that's really important to think about that.
Great, thank you. What strategies do you consider useful to approach a patient who is polymedicated in an inadequate way and has been on his or her medication for a long time?
So I think that really very nicely links back to the strategies that we use are about implementing the 7-step process. So even if an individual has been on a medication for a very long time, it's doing that assessment of are all these medicines needed and are they getting the benefits out of all of them? And quite often what you find is that as a person gets older, their condition changes or their needs change, or we've got a change in renal or kidney function or liver function, sorry, and it might mean that we therefore need to change the medication. It might also mean that an individual was diagnosed with a disease or a condition and there's been a change in that and therefore no longer needs that medication. So it's a really good point of saying, okay, I know that you were taking that medication before, but now we need to look at it again. This is the evidence now. How do you feel? We think that you should maybe change it or stop it. And they're the kind of conversations that you then need to agree with the patient so that they're happy to make those changes.
Okay, great. We have another question. One of the scenarios where we see the phenomenon of inadequate polymedication is the hospital. More specifically, sometimes several doctors end up evaluating a patient, the same patient, and sometimes repeat medication or don't review carefully the interactions. Or, for example, we can see some medication errors related to the administration of multiple medications. What activities would you recommend to minimize this at hospitals?
So one of the things in the hospital, in order to avoid that, is to do a medicines reconciliation. So to do the reconciliation when a patient comes in to the hospital, and at that point to review the medication, to see what they've been prescribed everything for, and also to check that the individual is actually taking everything that they've written on their list. Sometimes we find that a patient may have a list, but actually they haven't been taking some of the medicines before they came into hospital. So that's really important to get that history. It's then really important that as a patient may move from different doctors or wards within a hospital, that information is also shared. So if we make a decision, for example, that we're going to stop a medicine that's causing harm, we clearly document why we've stopped it, even if it was a preventative medicine. So we've assessed the risk and benefit and we share that information. And then finally, when the patient goes home or gets discharged, it's really important that the patient and carer have an accurate list, they understand what they're taking it for, but also so that information is then provided back to the provider that may be in the community, a primary care provider, so that we have a consistent record for the individual as they go through. Some countries, if they don't have the possibility to share that electronically, some of the other things that some countries do is they maybe have a patient held record or a medication passport. And sometimes it can be as simple as an exercise book that a patient carries and they list everything. Some countries also have apps where a patient can list all the medications and then record any changes that they may have. So these are just some of the things that can be used to make sure people don't keep changing an individual's treatment back or not recognizing any reviews and changes that have been made as a result of those reviews.
Okay. Well, Alpana, thank you so much for your great answers. We have a lot of questions, but due to the schedule, the rest of the questions will be addressed at the webpage. Thanks again for your presentation, Alpana.
Thank you very much for having me. Thanks. Bye-bye.
Bye.